So my patient is a 19-year-old male. He has a past medical history significant for a recently diagnosed superior mediastinal mass and primary hyperparathyroidism. I first met him on the inpatient consult service, and at that time he was post-op day 1 after a mediastinal mass resection. He was relatively healthy prior to his first hospitalization about 4 months ago. He presented to an outside hospital after sustaining a right upper extremity work-related injury. He worked for a shipping company and had wedged his arm in between a shipping crate and the wall, and so that was the reason why he first presented to the outside hospital. He had a CT chest that incidentally noted a 3.4 by 4.5 by 5.8 centimeter mass in the right paratracheal region with irregular enhancement and leftward displacement of the trachea. While he was at the outside hospital, he had an FNA done of that mass, and it demonstrated a few groups of epithelial cells in the background of lymphoid cells and pigment-laden histiocytes. He was then referred to Loyola for evaluation for surgical management. He presented to our ENT department, and that was the first time that we had labs in our system for him. And so he had a very high intact PTH. You can see it's around 6 times the upper limit of normal, measuring 434. And he also had an elevated calcium at that time, which was 12.4. He came back later on that month for a scheduled right mediastinal mass resection. And the labs you're seeing are 2 days after his right mediastinal mass resection. And at that time, his PTH after surgery had gone down to undetectable. His calcium was 8.5 when you correct it for albumin. It was around 9, and his phosphorus was low. He also had a 25 OH vitamin D that measured 16. So overall, he did pretty well on his hospitalization. He did have the complication of hungry bone. We had started him on oral calcitriol and calcium, and he was discharged without any other major issues. A few days after he was discharged, we received the pathology report, and it was read as an atypical parathyroid adenoma measuring 15.6 grams. The Ki-67 proliferation index was less than 1, and they did CD34 staining, which showed no definitive evidence of lymphovascular space invasion. However, they did make comments that the parathyroid tumor was characterized by cystic spaces, fibrous bands, and capsular infiltration. But again, they said no evidence of lymphovascular space invasion. The mitotic activity was 1 mitosis per 50 high power fields, and the Ki-67 proliferation index, again, was less than 1%. But given the clinical history of a PTH that was in the 400s and his hypercalcemia, they were understandably concerned about parathyroid carcinoma. However, they did not have the morphological features to call it that. They also made special mention of the cystic changes in the parathyroid tumor that are striking and raise the possibility of hyperparathyroidism-Jaw Tumor syndrome. And at the time that I read this, I'd really never heard anything about that, so I thought it was important to learn more about the condition. We all know about primary hyperparathyroidism. It affects 1 in 1,000 individuals in the general population, and the vast majority of cases are caused by a parathyroid adenoma in one of the glands. About 5 to 10% of patients with hyperparathyroidism have a family history of parathyroid tumors. So, I think it's important to recognize this group of patients and the syndromes associated with it. And so, briefly, we've all seen this chart, and it talks about the familial disorders associated with hyperparathyroidism. So it's MEN1, MEN2, hyperparathyroidism-Jaw Tumor syndrome, and others that we see less commonly but are well known, FHH, and then one pediatric condition on the bottom, neonatal severe hyperparathyroidism. So a little bit more about the syndrome. It was first reported in 1958 and is inherited as an autosomal dominant syndrome with high penetrance for the presence of parathyroid tumors. It's quite rare. It's a multi-tumor syndrome that includes parathyroid tumors, fibroosseous lesions in the mandible and the maxilla. It also has renal manifestations, and in a handful of case reports I have seen uterine tumors associated with the condition. As I mentioned before, it was rare. In one review article, it reports that they were only able to find 223 cases over an 11-year span. They do have more information regarding the syndrome, however. It is linked to a mutation in the long arm of chromosome 1, and the gene was identified as HPT-JT and encodes for a protein called Parafibromin. So again, this is a patient that was affected by HPT-JT. And as I mentioned, parathyroid tumors have a high penetrance in this condition. They mention that around 90% of patients that are diagnosed with this will have a parathyroid tumor. I think it's also important to mention that these patients are at a higher risk for parathyroid carcinoma. 15% of the parathyroid tumors are found to be malignant. And when you consider how rare parathyroid carcinoma is, I think it's really important to recognize the malignancy potential. The maxilla and mandible cemento-ossifying fibromas occur in 30% of patients, and it's probably the most striking part of the disease. I think it's important to draw a distinction between brown tumors associated with hyperparathyroidism and these tumors, and we can talk a little bit more about that later if we have time. But brown tumors, resolve after treatment of the hyperparathyroidism. However, that's not the case with HPT-JT. And as I mentioned, there's a renal component as well, with renal cysts occurring in about 10% of patients, but renal cell carcinoma, Wilms tumors, and hamartomas have also been described in these patients. And like I mentioned, not every female patient has uterine tumors. It's only been reported in less than 10 cases that I've seen, but I thought it was good to mention. Parafibromin is the protein associated with the mutation, and the loss of parafibromin protein expression has been observed in sporadic parathyroid carcinoma as well as in parathyroid carcinomas associated with HPT-JT. If you look at sporadic benign parathyroid adenomas or familial parathyroid adenomas not associated with the syndrome, they do not have a loss of parafibromin expression. The parafibromin, and there have been small studies, again, 16 patients with parathyroid adenoma and 8 patients with parathyroid carcinoma. You have to take into consideration that it's a very rare condition, and so the numbers are just not going to be that high in these studies. And the parafibromin stained strongly positive in 12 of 18 of the benign adenomas, while only positive in 2 of 8 carcinomas. And really what that tells us is parafibromin immunostaining is a normal variant in benign adenomas. However, when you look at parathyroid carcinomas, it is seen in only a portion of them. So 75% of the carcinomas that they looked at did not have the parafibromin staining. And so I looked more into the pathogenesis, and just because of the interest of time, I won't go into it, but we've learned a lot about Wnt over the past 2 weeks. And so it is involved in the PAF complex that eventually affects Wnt signaling down the road. And then I also was looking more into this condition as well, and I found a paper by Dr. Belzikian, which is great to see a familiar name amongst the papers that you're reviewing. And so, again, very important to mention this increased risk of parathyroid carcinoma. We've talked about how rare it is, and 15% of the patients with this syndrome do develop parathyroid carcinoma. And I think it's important, we do know the gene mutation that's associated with it, and that it is well accepted that it plays a role in the molecular pathogenesis of a parathyroid carcinoma. Even cases that are not associated with Hyperparathyroidism-Jaw Tumor syndrome have been shown to have the same genetic mutation as well. So this patient we later presented at Tumor Board because the pathology report showed the capsular infiltration but no lymphovascular invasion, and given the cystic nature of the parathyroid tumor, our concern was that maybe he would be at an increased risk from malignancy. And so we wanted to get others' opinion regarding this, and we were hoping to talk to Pathology to convince them to do a Parafibromin stain for us. Unfortunately, we were not able to get the Parafibromin staining on the surgical specimen, but really all they told us is, recommendation was to watch closely, do follow-up testing, and recommend genetic testing. So unfortunately, this patient has been difficult to get a hold of. So him and his family both don't have a lot of medical care. They didn't have a lot of medical issues before they came in, so it's not really that high on the priority list. But whenever he does come in, we update his family history, make sure there's no history of parathyroid disease, calcium abnormalities, kidney stones, renal cysts, etc. His labs, his most recent labs are there. You can see his vitamin D, 25 vitamin D is still low, but his calcium is normal and his intact PTH is only 67. So our plans are to keep a very close eye on his PTH and calcium. And if we see any hypercalcemia or an increase in his PTH, we'd be very aggressive in our monitoring of the patient. Our plans for him are for him to undergo HPT-JT testing. And we had considered doing x-rays of the mandible, maxilla, and renal ultrasounds to see if he has any other signs or symptoms of this condition, but we haven't been able to do that quite yet. So the take home, if the genetics testing is positive for this HPT2 mutation, it would mean that all the parathyroid glands remain at increased risk for developing entirely new tumors and would be potentially malignant. So again, we will keep a close eye on his calcium and PTH and be aggressive about our workup and our management from that point on.